Good morning, everybody. I'm Rachel. I'm the Chief Executive of the Patients Association. And thank you so much for joining us this morning to discuss the future of diagnostic testing for patients. The webinar will be recorded. The normal, use the chat box to say hello to each other. Please go over to Q&A when you have a chance for any questions that you have. We want this to be as interactive as possible. Closed captions function has been enabled, and just adequate. Let's not take pictures or screenshots of speakers if possible. Thank you. So this is about a report that we were very grateful for Roche for funding us to do this report. And before I get started, I want us to actually just reflect on what we heard directly from patients when we were doing the report. We heard from over 1,100 patients and some really powerful testimonies there. So before we get into the main kind of key findings of the report, I just want to play you a couple of snippets maybe.
Delays mean more deterioration and will cost the NHS more as patients are sicker. Investing in diagnostics is expensive in the short term, but cost effective in the long term.
There needs to be one consistent approach adopted by all GPs and clinics so that patients are informed of the result no matter what.
Realistic and improved waiting times. If you were told urgent, 7 months is not acceptable.
If there could be more triage for diagnostics on a local basis, this could make life better. Local health centres and pharmacies, local community hospitals would be my choice of frontline diagnostics.
More explanation of tests available and wider availability of tests. It's preventative healthcare, so could help reduce pressure on the NHS.
Doing diagnostics at home yourself would be good, as long as people were shown how to carry this out, or it was made as simple as the COVID test.
My partner died through the GP not offering any tests and a misdiagnosis saying they had arthritis when it was kidney cancer. The hospital was amazed at how it was missed.
The problem is predominantly the wait for diagnostic procedures and then the wait to see a consultant and for treatment. In my daughter's case, it took 18 months to diagnose a break in her upper spine, and it was too late for surgical repair. She's in permanent pain.
I lost a young family member because they had to wait a whole year before their GP referred them for an endoscopy. It took for him to pass out in the GP clinic for them to get the endoscopy done, and by then it was too late. He passed away aged 30 from stomach cancer. The outcome might not have been different, but it could have saved him a year of pain and suffering.
Okay, so that grounds us in what we heard from patients in the survey, which I think is a really important place for us to start. And we've got a fabulous panel here that are going to discuss the future of diagnostics. And I think for me that these were the recommendations in the report, and we will now be able to we'll get to the copy of the full report in the chat, and the recommendations are as there, the importance. But the clear message that we got from patients in this report was diagnostics is a fundamental part of what the NHS provides, and one that needs to be prioritised by decision makers, both in the health service and in government over the coming years. That needs to be done in genuine partnership with patients, and that patients' experiences of diagnostics should be included in a review of what the NHS Constitution is delivering for patients. Widely recognised that diagnostics have a key role to play in helping the health system recover from the pandemic, which continues to have an impact on the experiences patients have in the NHS. So we're going to go into all of these, all of these recommendations, but I don't want you to be just listening to me, so I'm going to introduce you to our panel now. And I'm delighted that we have Dr. Ashton Harper joining us, who's the Head of Medical Affairs, Access and Innovation at Roche Diagnostics. Professor Mike Richards, thank you, who was National Cancer Director. I think I might have your job title slightly wrong, at the Department of Health. And Karen Stalbow, who has the longest job title, which is Deputy Director of Policy and Performance Diagnostic Programme for NHS England. So I'm going to hand over first to Dr. Ashton Harper to give his reflections on what you heard in the report from patients.
Thanks, Rachel. So I'm Ashton Harper. I'm Head of Medical Affairs for Roche Diagnostics in the UK and Ireland. My team supports doctors at many universities and hospitals to generate evidence of how effective our tests are in identifying cancers, infections, and diseases affecting the heart and brain. So Roche Diagnostics is one of the world's largest and leading providers of diagnostic testing, and we've operated in the UK since 1908 and have been a committed partner to the NHS since its creation in 1948. In 2022, over 750 million Roche tests were used in the UK alone to identify diseases, detect infections, and help clinicians to make informed decisions about the best course of treatment and care for patients. We're an extremely purpose-driven organisation, and as such, we work with healthcare professionals across the NHS to try and improve patient access to diagnostics and ensure these tests are getting to the people who need them. Those of us who work in diagnostics know that the many benefits of early and accurate testing for getting patients on the right treatment in emergencies or helping them manage long-term conditions, or sometimes even preventing illness altogether with screening programs, for example, which can detect disease before any symptoms are apparent. I myself worked as a doctor in the NHS before joining industry, and it's hard to imagine doing that job without a whole range of diagnostic tests that are available in a modern healthcare system. It's been estimated that diagnostic tests inform 70% of all clinical decisions taken in the NHS, and I'm surprised this figure isn't actually higher, certainly in hospital settings anyway. And just as the physical benefits of testing are crucial, so too are the psychological and emotional benefits for patients of getting the answers they need to help them understand why they are feeling the way they are and what they can potentially do to feel better. Across Roche, we talk a lot about doing now what patients need next, and we embarked on this partnership with the Patient Association because we're very aware that the best way to know what patients need next is to ask them directly. Overall, we were really pleased to see that the survey findings confirmed that an overwhelming majority of patients view diagnostics as a fundamental part of the NHS and want to see them prioritised in the future. Patients also said they want to know how to get the tests they need, why they are having them, and when they expect results, which all seems very reasonable and achievable, and thus more needs to be done to make this a reality. And whilst the report obviously highlights some of the barriers to access which exist, patients are experiencing, it also tells a positive story of patients' desire for empowerment, their willingness to be proactive, and openness to new and innovative ways of doing things. So being mindful of time, I just wanted to highlight a couple of insights from the report that really stood out to me. So a number of the questions asked about when and how patients would like to access testing, and the responses showed that the large majority of patients would like to see expanded opportunities to access diagnostic testing and that they are willing to test themselves. For example, almost 80% of patients felt testing facilities should be provided closer to home to make access easier. The pandemic was a watershed moment in both the understanding and acceptance of both point of care and at-home testing, and we are definitely seeing a real drive in the development of these technologies. In the months and years ahead, I think we can expect to see a proliferation of handheld and portable diagnostic tools that deliver quick and reliable results, possibly in patients' homes, but definitely in more local and community locations beyond traditional healthcare settings. I'm hopeful that this approach will also help the NHS to meet its net zero ambitions by, amongst other factors, reducing unnecessary travel to hospital. And it's really great to know that patients would like to see more of this type of testing, as these devices have the potential to help address major public health challenges, such as diabetes, cardiovascular disease, and outbreaks of infection, as well as monitoring of chronic conditions and facilitating rapid decision-making in emergency situations. The other findings I wanted to highlight were the two that related to testing for Alzheimer's disease. Today, tests exist for Alzheimer's disease that are able to diagnose it while symptoms are still very mild, and in fact, even before they develop at all. But they are not widely used in the UK currently because disease-modifying treatments, these are medicines capable of slowing the disease down, are not yet available here, although it's likely they will be later this year. So we asked whether people would be likely to take such a test if it was available to them, and nearly 3/4 of respondents said they would. And nearly 90% of those surveyed said if these tests revealed that they were likely to develop Alzheimer's, they would make lifestyle changes that might delay the onset of symptoms. The disease-modifying treatments for Alzheimer's will undoubtedly be a game changer in the fight against this cruel disease, but I think it's really interesting that these findings showed that even before these treatments are available, armed with an early diagnosis, the majority of patients would take their health into their own hands and make lifestyle changes. And it's worth noting that those lifestyle changes are the same ones that could help reduce the risk of cancer, cardiovascular disease, and many other long-term and life-limiting conditions. And the final point I wanted to make is that, as well as showing that patients see and understand the importance of diagnostic tests and will proactively seek them out to find the answers they need about their own health, it was also great to learn that patients believe prioritising diagnostic services can help to relieve the huge pressure on our NHS today and protect it for the generations to come, a belief I, for one, also definitely share. So thank you very much.
Thank you so much, Ashton, and that's a really helpful introduction. Mike, you and I have talked about this report a couple of times, and I think you've a couple of areas that you'd like to focus in on.
Thanks very much, Rachel. I think this is a really, really important report, and I'm very grateful to both Roche and the Patients Association for undertaking it, because we need to know the patient's views, and we've heard them clearly. Now, they happen to coincide exactly with my thinking too, which is always convenient, but being able to say this isn't just us saying it as professionals, it is what patients say as well, is really very important. How do I come into this? I was many years ago the National Cancer Director, but more recently I have been focusing on diagnostics because I was asked to undertake an independent review of diagnostic services. This is back in 2019, before the pandemic. And it was already apparent then that waiting times were getting longer, that we were having to outsource more of the work to the independent sector because we just didn't have the capacity in the NHS. We had far fewer scanners than other countries. So at that point, even before the pandemic, we were reaching a tipping point. And then the pandemic made things a whole lot worse. And so I talked to a large number of people about diagnostics and coming to my conclusions in my report. There are 24 recommendations in my report, but I won't go through all of those, I promise you, because you can boil it down really to two key elements. We desperately needed more capacity, and by that I mean we needed more scanners, more machines of all different sorts for diagnostics, better facilities to house them in, and also we needed a much greater emphasis on getting the right workforce for diagnostics. But the second element was that if we had that greater capacity, we needed to do things differently. And part of that, and a big part of that, has been to establish community diagnostic centres. In other words, not doing all of diagnostics or almost all of diagnostics in acute hospitals, but bringing them closer to patients. But it was also about getting hospitals and these community diagnostic centres to work closely together in networks. We needed better leadership for diagnostics. We needed to plan for all the innovations that were coming along, including artificial intelligence. And we needed really to think about what can be done at home. Now, Karen's going to talk more about that, so I won't go into that, but it's another important element. So by and large, this was about moving away from everything being only done in acute hospitals. And I published my report back in October 2020, and I'm pleased to say that it was very well received by NHS England and the Department of Health, and also, very importantly, by the Treasury. And we got really substantial funding to get things underway. And we now have, I think it's 155 of these community diagnostic centres up and running. And we're learning a lot as we go about what really does make them effective. We should have 170 by this time next year. And actually, that's ahead of what I wrote in my report. I suggested 160. Now, it's not often that we end up doing better than an independent report says. So that, again, is really good news. On the other side of things, we do still have very long waits. And we need to acknowledge that, and we do acknowledge that. And so the job is not yet done. We are well underway and are gathering momentum, but NHS England now, and Karen is very central to that, is really actively thinking about what should be the next steps. And I think we all agree that we will need more of these community diagnostic centres. It's the right way to go, but we need to do all the other things, including what can be done at home. And we really need to tackle the waiting times. Just one final point from me. We have started to look at what is patients' experience of these community diagnostic centres. And I'm really delighted to say that so far it's been extremely positive. We've been asking people about how they got their appointment, what it was like when they first arrived in the community diagnostic centre, what was their experience of having the test itself and getting the results, and etc. The whole of the journey through the centre, and they've been really very positive. So, of course, some things that can be improved on, and that will be useful to the individual community diagnostic centres so that they really know where to focus their efforts. And I've been fortunate enough to visit quite a number of these places. I'm not keeping up with it. I haven't been to all 155. I wish I had, but every time I do go to one, well, first of all, I see the enthusiasm that there is from staff and patients, and secondly, I learn things for the future. So I think it's really exciting that we've got this programme. But coming back to where we started, it's really exciting that this is what patients would want prioritised as well. So I'll stop there, Rachel.
Mike, thank you so much, and it's a real honour to have you with us today, because you have been around looking at diagnostics and lots of other things within the health service for a number of years, and you're completely right. There was a huge understanding about the role of community diagnostics and how that can help. But in addition to that, almost 4 in 5, 78% of patients said that they would be willing to travel outside their area if it meant that they were able to access diagnostic testing or screening faster. So patients want to work in partnership to get this right for patients. Karen, I'm going to hand it over to you now, because you're going to give us a little bit of background on what's happening in NHS England around diagnostics.
Excellent. Thank you so much. And thank you, huge thank you for this opportunity to join you today. I have to say that hearing those testimonies at the very beginning was not only incredibly important, but also really quite emotional in places, and I massively appreciate that opportunity to hear those voices. I think the report is really instrumental and key in our forward thinking, as Mike has said, really getting that opportunity to understand what patients think and what their priorities are and what they want to see now and in the future is going to be really important to us in the thinking that we develop going forward. And we are in a position, as Mike said, where we are thinking about our next steps. I think it was suggested to me that I kind of focus on some of the key areas that came up in the report around at-home diagnostics and also point of care testing. And so I'm going to ever so slightly future pace us in relation to that. And of course, it's important that, the positioning for these types of at-home diagnostics, of course, started during the pandemic, where we became a bit more, I wouldn't say comfortable, but certainly we got used to testing ourselves. And I suppose, we've kind of potentially not acknowledged the fact that for years and years, pregnancy testing and anyone who's tested in that way has used a test at home to inform them and to kind of give them a sense of a particular situation that they can then go to a clinician and get confirmed and assessed. And so this has kind of given us an opportunity to really think about the other types of at-home testing that the NHS could be making available. And in some circumstances, that's an opportunity to be able to monitor patients at home. So perhaps patients have chronic conditions, perhaps they're kind of making regular trips to hospitals and for appointments. But what if they could monitor at home and their clinical team or their doctors would be able to have regular access to those results? And this would mean that patients would be able to get intervention, access to treatments and care at the most appropriate point when they really need it, rather than attending appointments when actually they potentially feel fine. This is about that opportunity to really get in when patients need it, to provide them with the treatment and care that they need. And we're already seeing early examples of this, for example, for conditions like macular degeneration and also for chronic obstructive pulmonary disease. And they're being piloted at the moment across the NHS. And we hope that they get to a position where they produce the results that enable us to be able to expand their use wider. There's also things like blood pressure monitoring. And you know, we've built on the experiences of at-home oximetry during the pandemic, and there has been a programme available to provide blood pressure monitors so that people can, you know, be using that to check how they are. And patients can follow really clear and simple instructions. And I think that was also in one of the testimonies. I'd be happy to test something at home if there were clear and easy instructions available to me to know exactly what I could do on the basis of the different results. And what if, and I suppose this was also a testimony, so there was talk about being able to test in the community or at pharmacy. But what if you could get tests done at the chemist? I mean, we're not there yet, but, you know, perhaps it could show as chemists get, you know, pharmacists get more powers to be able to provide particular treatments and also to be able to prescribe antibiotics. What if they could test you to see whether you had the type of condition that required antibiotics so that they were able to give you the most appropriate treatment you needed? Or what if ambulance crews could undertake tests to safely decide whether a conveyance, whether a patient needed to go to A&E or not, perhaps when they have chest pains? These types of tests are available in hospital. We all know what it's like to have to wait for the results from pathology department laboratories, and we've sat there and done so. But in the future, what if there's potential for them to take place at point of care, and that point of care could be at home or in the community? We're not there yet, but what the testing done during the pandemic shows us is that in the future, we could be. And that was as much as I was going to say. I hope that's okay.
That's lovely. Thank you so much, Karen. And I think you picked on two issues that were really important to patients in this report. And that was the increased transparency in waiting times. Patients really kept saying, and there is somebody in the chat box earlier on talked about scan anxiety and the impact it has on people when they're waiting to either have a test or waiting to get the results of tests. And what the report is asking of NHS England is to initiate a programme of work with local system partners that can help us to reach a point where patients have clear understanding of how long they will wait for a test to take place and how long the results will be. And I think this is across the system as well, because I know when I speak to lots of patients about being on elective recovery and a list, is just that communication that says, you know, we will get in touch with you, because if you're waiting for a test, you can believe that people have forgotten about your test or your test results have got mislaid. You know, GPs saying, oh, well, if you don't hear from us, then the test is okay. That's never good enough for me, because I'm always, you know, my anxiety will be, maybe they've forgotten to tell me. So is there any work within NHS England looking at how we might work in partnership with patients to keep them informed before, during and after their tests?
So there is early work around the NHS app and the opportunity for patients to be able to manage their appointments. And that's in its early infancy, and it's available for some tests and obviously available to those who are comfortable in using an app to be able to engage with the health system in that way. And so there's probably work we need to do to understand how we make that significantly more equitable and inclusive. And equally, I think there is more to be done as well in sort of making the app available in that way. We've also explored the opportunity to make results available through the app. And again, I recognise that isn't inclusive for everybody. And we have to think about that really carefully, I think, because there are some results where actually it's really easy to know and to understand exactly what that means. So your blood test is negative or your scan is negative, you don't have to worry about that. But actually when it shows something, that sometimes needs a discussion and a communication so that patients can really understand what that test means. And so it may not always necessarily be appropriate to make that available digitally, but there should be a mechanism in place where patients have that opportunity to speak to their clinical team to be able to understand those results. It's challenging for us at the moment to be able to say when those results will be available, simply because we struggle with the workforce and having those available to be able to determine specifically what a turnaround time is going to be. But as we move forward and we really expand and deliver to the ambitions that Mike set out for us, we hope in the future to be in a position where we can be delivering to the turnaround times and to the targets that the NHS is set.
Thank you, Karen, because I think, you know, nearly 1 in 5, so 17% said their long-term recovery was set back due to delays in tests and results. Around twice as many faced issues with their physical and mental health and their work and family life. And you know, notwithstanding the need for more scanners, the workforce issues that are going on, I think it would be great if we had, through Diagnostics, I know Healthwatch are on the call. I don't know if National Voices are, but Healthwatch, National Voices, and the Patients Association, I forgot who we were for a second, did some work with the elective recovery around communication principles that are sitting on NHS England's website. We can reissue those again. But that was because I think, you know, if we work in partnership with patients will understand. But what people have said to me in the past is, you know, if they're going to say, you know, you're going to hear from me in 3 weeks' time, but in 3 weeks' time, it might be, look, we haven't heard yet. It helps with anxiety. It helps with the stress of waiting for those results and not knowing where they're coming from. And you are so right, Karen, about the communication with patients where the test may be positive. So somewhere one of my team showed me an example of a letter that a patient received that was written to the patient, and Mike, you'll like this because I know you'll disagree with it, but it was written to the patient, but it wasn't. It said, "Dear Rachel," but the rest of it was completely medical, and it was around the prostate cancer test. And they sent it on to us, and I couldn't understand it. So, you know, there's some things in the diagnostic strategy about plain, accessible English and writing to the patient. And I think that's where I think we could work with you, Karen, and so other patient charities to really make sure that we have something that's developed in partnership with patients. And I think Louise just come on from Healthwatch just saying there that, you know, the communication infrastructure is as important as the tests. And Mike, I want to come back to you about, because you knew I'd come back to you. I want to come back to you about the community hubs. How do patients find out about where a community hub is? And I think Karen brought up the question about pharmacy, and we did pharmacy first webinar last week to explain the new changes to pharmacy. And people were asking then, you know, can't pharmacists do tests? Can we create hubs in that way that they're situated on the high road?
So when we started the programme with the community diagnostic centres, we knew roughly how many we were aiming for and how many, frankly, that we had the money for. But of course, it was not a decision made at the centre exactly where each community diagnostic centre would be. I don't know the geography of the country in that much detail, and where the need is and the demographics, etc. So we worked very closely with regions and then with the integrated care systems to plan, and they came forward with the plans, and they are the ones who are making it known, first of all, to GPs and to consultants exactly where these are, and then hopefully widely making this available to patients. And it is a changing picture all the time. As I say, there are new ones being opened almost as we speak. But it should be available locally. We do have a map of it centrally, but I'm not sure how much help that would be. But we also know that we've looked quite carefully at what the travel times are, and this should actually improve access. And if I just give you one example, the Community Diagnostic Centre in Clacton-on-Sea in Essex, but prior to that existing, it was a 2-hour travel for people to get from Clacton to Colchester by public transport to get a scan. Now they have it on their doorstep. There was a pre-existing community hospital in Clacton, which had some unused space, which has now been converted into a community diagnostic centre. And I think that story, and in some places the community diagnostic centres are in shopping centres. There's one in North London in Wood Green Shopping City, and there's another one in Barnsley, in the Barnsley Glassworks. Now I can't go around all 155 because I simply don't know them all, but you know, so there are various different models, and what we're now doing is actually finding out what really works best about all of these different models.
Brilliant, thank you. Mike, I'm going to ask you another question, then I want to come to Ashton with a question. So there's questions coming in, and Karen, I suppose it's both of you, or maybe it's just a plea, because there's issues, there's questions and there's comments coming into the chat and the Q&A, which are talking about, you know, one person saying, well, the GP had my result and it took 3 weeks for it to get to me. Somebody else saying that 1 in 4 patients' cancer tests not the patients not being able to understand them. So how do we get the diagnostic strategy moving forward to really understand the role of patient partnership, the role of shared decision making? And that starts with, you know, accessible English. We've got a health literacy age between 9 and 11 in the country. And it is not, as somebody said to me, it is, you know, when I said we need to be writing at that level, and then all of us can understand it, and we can take the ownership that we hear from patients all the time, which is like we heard, Ashton, when you referred to the Alzheimer's tests. Patients said, yeah, well, I'd be willing to do that test, and then I'd be willing to maybe change my lifestyle to try and address that. So if we're going to go into prevention and self-care, which we have to, the system has to communicate in a different way.
I couldn't agree with you more. In fact, I have been banging on about this for 24 years because there was an NHS plan back in the year 2000, and one of the recommendations we made then was, particularly from hospitals, that the hospital doctors should write directly to the patient, and the copy would go to the GP. Unfortunately, that idea got mangled, and it was a letter to the GP should get copied to the patient. Now, the idea was if it was a letter written to the patient, that would actually effectively force doctors to write it in language that they could understand. And I'm still trying to get that reversed 24 years on. So any help you can give on that one, and that's me speaking entirely personally.
You've laid the challenge. You've laid the challenge. There is many patient associations and many patient organisations out there quite happy to support with that piece of work, and genuinely there are. And I think it's something about. If I bring us back to the piece of work that we've just led on with the outpatients, bringing patients together to start the development of the outpatient strategy and having patients at the table with clinicians to develop it was a very moving experience for everyone involved and effective.
Incidentally, the GPs I talked to at the time were also in favour of it because their comment was, we might be able to understand the letters as well if they were written in language that the patient would understand. We would understand it too. So they weren't opposed to it at all. Anyway, we can go on fighting that battle.
We will go on fighting that battle because actually that's a real theme coming out here. Somebody else saying a letter from a breast cancer surgery saying, I need to ring Charity Breast Care now to find out what it's actually saying on a Saturday morning. We're adding more stress to patients, and that's just not right, is it? No. Ashton, so how, I've been talking quite a lot about partnership here and patients partnering with the system, but I see industry as core in that partnership. How do you feel we could get to a better place in the future around diagnostics and diagnostic screening?
Yeah, I think any opportunity really to improve communication between patients and working with charities, which work that we already do quite broadly, but trying to really understand where patients feel like their needs are not being met, and then trying to work out solutions to meet those. And it's not any one player. I think it's the industry communicating with the NHS and again with patient charities and NICE, MHRA, and there are some really interesting programs that are coming out to try to enhance communication between all these really critical different parts of the system. But that's what it sort of comes down to. And we've done some work, for instance, in heart failure, where we've actually gone and asked directly, many patients to see where are the pain points. How are they being let down? Are they facing delays in diagnosis or being misdiagnosed, and trying to work out how can we try to improve that situation. So I think there's basically no substitute for directly contacting and hearing directly from patients, as we've obviously done in this work with you just now.
Yeah, brilliant. So, Karen, I want to come back to home testing a little bit. And there is a question in the Q&A about what conditions need to be in place. And we've talked about health literacy and how we might give patients the power to be able to do more testing at home. And it reminded me of the COVID testing and watching two extremely highly intelligent members of my family doing a COVID test on each other and telling them that they were doing it totally wrong. So how can we get that partnership going, that we can really understand what patients need to understand and how we can give them that power and the confidence to do that diagnosis and to do that diagnosing at home?
So I think at home testing is a huge opportunity to enable patients to spend less time traveling backwards and forwards to diagnostic centres, to hospitals and so on. I think it's really key and critical that it's supported by clinical teams so that patients can receive and understand and learn the best ways to take the test. Some tests are quite complicated. If you think about the tests like spirometry for COPD, it takes time to be able to learn and to develop how to do that effectively and properly. And you want it to be effective, and you want it to be done in a way where you can then really rely on the results that come through. There's no point using a blood pressure monitor in a way that makes you think that actually your blood pressure is much higher than it actually is. And so for us, it's really critical that not only the test is part of a pathway and that it makes life easier for patients, but it has to be clinically supported. And those results have to be available to clinical teams so that not only are they acted upon as effectively and efficiently as possible, but that anything a patient doesn't understand about the result, they've got someone to talk to about that. And I think without that clinical support, you know, unless it's a test that gives you a binary yes or no, it's really important that patients have access to clinical teams that they can discuss those results with.
Brilliant. Thank you, Karen. Communication is coming up time and time again. So I think there's something that we really need to think about, Karen, how we can support NHSE with this. So somebody's brought up the stage of the postal system and people getting their letters late. And Health Watch led with the Patient Association, National Voices, and actually contacting Royal Mail and are having a conversation with them around the decision to delay that 2 to 3 day and talking to them. So notwithstanding the postal delays that can happen with diagnostics coming out there, the Kidney Care UK in their recent report said that people were finding out that they had chronic kidney disease from checking the NHS app. Now, that's great. And there's something about shared decision making and how you get that result, you know, and to open your app maybe late on a Friday night when there's nobody else. And we hear this regularly from patients as well. Do not let me get a letter at 5 o'clock on a Friday evening and I can't get through to somebody or get to discuss the distress I might be feeling as a result. So, the app is great. Letters are great. What other ways are NHS England considering having that kind of two-way shared decision making? We've had questions about informed consent in the chat. You know, you're not doing informed consent if you walk into somewhere and they go, we're about to do a test on this, because you haven't had that conversation. I don't know what the answer is, but it's coming out quite loud and clear that this is an issue. Mike, I don't know whether you've got a view on this, or Ashton or Karen.
Well, I suppose the starting point is that whoever is referring a patient for a test should hopefully explain to the patient why they're doing it and what it will involve. But then that can be supplemented with information coming from whoever is providing the test, let's say the Community Diagnostics Centre, actually explaining in more detail perhaps and sending written information about the test. And I'm a great believer that we should use all communication channels. Yes, the old-fashioned snail mail is there, but in the rest of my daily life, I get huge numbers of communications, either by text or by email, you know, whether it's from British Gas or whoever. And as long as I've said I'm happy to receive it in that way, not that British Gas has ever asked me whether I'm happy to receive it in that way, but I think with the NHS, you know, would you mind getting this by email or by text? People probably retain their email address longer than they do a home address. And so we might get fewer patients lost in the system if we used email. And I don't know, I've had my same mobile phone number for God knows how many years. I may have changed the phone, but not the phone number. So I think we should use all of those approaches, and we should ask the patient which of those they want us to use.
Can I come in? I was just going to say, I think what was coming out from the report as well is not just knowing about that next test, but actually sort of longer longer down the line, you know, if that test is positive or negative, this is going to be the next step. So, and there might be actually a number of different tests in that process, and you're not going to tell them about 10 different things in a row, but actually having some understanding of what the next thing might be, because patients might feel like, well, I'm just going to have this next test and that's kind of it sorted. So I think maybe a bit more understanding of the sort of the next step after what you're sending them for might be helpful.
Absolutely. Karen, were you going to come in?
Well, I was going to say that, you know, the pandemic gave us virtual consultations and it gave us telephone calls, and, you know, I can remember you know, being given a slot and a time when I was going to be phoned by a doctor. And I think, you know, maybe there are more opportunities around that, and the opportunity to phone someone with their results and to talk it through with them. I think we're always going to have to balance that against naturally the pressures that the NHS is under at the moment. And that, you know, sometimes the ways in which communications currently happen is a consequence of that. That doesn't make it right. But I think we have to think of ways in which we can deliver solutions that are effective for patients, that also balance that, obviously, with the considerable pressure that workforce and services are currently under. And as we move away from that level of pressure, you know, hopefully we can put things in place that make it much more that give a long-term effectiveness to that communication.
Brilliant. Yeah, and you know, rightly people are saying in the chat and the Q&As is it not all systems will suit all people. So it is about that shared decision making. And I think, Mike, you're right. And I'm seeing questions in there as well as how do we build, you know, if we look at the role of the expanding pharmacy primary care team, how that role, how those newer roles like your care navigators, all the healthcare roles in there, how they can support patients with that kind of shared decision making about why you're going for the test, what's coming next, as you said, Ashton, how we're going to communicate with you about the test results, what's going to work for you. And Karen, you're right, maybe it is something about more, you know, the telephone calls will work for some people, other people don't want to get a letter, other people do want to get a letter. And somebody's rightly said, we need to look at how people can trust the correspondence that they're getting from NHS trusts in terms of the kind of number of scams that are out there at the moment. I know as an organisation, we get so many, you know, the team get messages from me at the moment. It's the latest scam out there, but, you know, last week we had 3 messages that looked very much like they were like from me asking them to do specific things. When you look at the address, it's not, but there are things we need to think about so that we have that trust in communications as well. Thank you. The questions are coming in. I haven't got time to breathe trying to get through these questions. So I can't answer this question, but I'm going to ask it because it did come up in the role of artificial intelligence in testing. Anyone want to come back on that one?
Well, I start on that, and Karen may want to follow on. I think it's got huge promise for diagnostics, and it's already being used in some areas. So, for example, if somebody goes to an A&E department with a possible stroke, the interpretation of the scan they have, artificial intelligence can do that very well, and that can help decide whether somebody would benefit from being sent on to a specialist centre where they can actually have a procedure to try and remove the clot that's causing the stroke. And that where time is absolutely of the essence. Now, that same scan will be checked by the person doing the procedure, and that's fine. So it is already happening. In that area. We are already seeing artificial intelligence being used in some places for photographs of moles that could be skin cancers, and that's being tested. It's being tested for interpreting mammograms for breast screening across the board. It's already being used to a certain extent for the new lung screening program. So yes, it's coming, but we've got to do it safely. And that does mean getting the evidence that artificial intelligence is at least as good as the human. And equally, in many cases, we'll then be having one human being and one machine are working together. Will that change how the human being interprets a scan or an image or whatever? So I'm absolutely sure that this is coming. It will help us in terms of both speed and the workforce, but we've got to do it safely. We won't be thanked if we don't.
Does anyone else want to come in on AI?
Well, completely agree with what Mike said. I mean, there's lots of different applications, and also, within the area of cancer as well. So looking at digital pathology and analysing cancer specimens to look at whether biopsies, rather, to look at whether certain medications are indicated or not for patients. So really helping, personalised, targeted treatment, but also, for combining different diagnostic and data sets together. For instance, there's some really interesting work in terms of looking at early warning scores. So within hospital, being able to determine whether patients are likely to have a myocardial infarction or needing to have to go to acute intensive care. So some really interesting applications there. And again, I agree with Mike that I think they've got a lot of potential, but we need to make sure that they're safe before we roll them out on a wide scale.
Brilliant. Karen, not putting you on the spot, but I think it's been covered. But is there anything you want to say about AI?
No, I think it's all been covered incredibly well. It has a massive amount of potential. We do need to pilot and validate it to make sure that it's going to be safe.
Thank you. Okay, back to the questions again. So there's a lot of questions about workforce, which is pretty key to this whole future of diagnostics. And whilst I've heard reports of more scanners and just news going in my ear, it can't be done without more staff.
And I can assure you that workforce and the staff element was a major component of my report, and it's a major component of our ongoing thinking. But so we are training more people and building the workforce, but we're also trying to work, and I'm going to steal one of Karen's phrases now, to work smarter. In some cases, we would get more scans done if we actually had better support staff able to bring a patient from the emergency department to the scanner. That's been shown. So it's not just having the most highly trained radiologists and radiographers or others. It is about the whole of the workforce that we need to be thinking. Again, in some of the community diagnostic centres, they're setting up training for people to be coordinators, people to work on the front desk, all of those roles. So it's the whole way up the scale, if you like, that we need to be thinking about it. And there are new technology advances that really make a difference. If there are technology advances that can make an MRI scanner faster, we can then get through more patients per hour, and that is actually happening. So that's good news too. So there are lots of different things that we need to do, and of course, going back to AI, all of that. So it's yes, we need more workforce, but we also need to be thinking much more broadly than just saying it's numbers. We need to be thinking, where are the barriers and how can we get over them?
Absolutely, I couldn't agree more.
And just last year, of course, NHS England published the long-term workforce plan. That really is now a funded initiative that will grow reform and retain our workforce. And you know, that growth is going to be through training opportunities. The reform is, as Mike said, it's about really thinking how we use how the workforce is utilized much more effectively, and what opportunities we can provide to parts of the workforce to really be able to grow, to train, to develop. You know, we're seeing reporting radiographers, for example. You know, how do we really enhance the skill mix to ensure that we're giving the workforce opportunities to really develop and to grow, and through that greater opportunities for us to be able to retain what are unbelievably talented individuals.
Absolutely, Karen, and we welcomed the workforce plan in full and have worked with NHS England around the workforce plan. And it was an important milestone. But in our general election manifesto, we have also asked the NHS, the government, whichever government it is after the election, to pledge to fund and deliver the workforce plan in full, because that's needed. It is just a plan, whilst an ambitious one. But we've also asked the government to ensure that there's a report to Parliament every 2 years on newly identified gaps. So, Mike, you know, you said your report before COVID talked about workforce, and you're right, the admin workforce, the whole workforce of the NHS has to be part of that. But we also need to think about the legislation on safe staffing levels across the NHS for patient safety. And I think, you know, that's what we've heard here as well, is the important role of diagnostics in terms of patient safety. And we are out of time now. I want to thank you all. I'm sorry I've been throwing questions at you. And I just want to finish with a quote that you're going to have to hear me say to you, but this was a quote coming from a patient as well, which is in our executive summary. So, taking a patient-centered approach in diagnostics can involve clear communication, involving patients into decision-making and addressing their concerns and preferences. And I think, Karen, in your role as Deputy Director, you've heard a lot from patients this morning around taking that person-centered approach as we develop the plans. So if we do partnership in design and delivery of plans, there will be better outcomes for both staff and for patients, and Mike, a better use of resources, as you talked about. So I will leave it there. I want to thank you all for attending, and thank all our participants as well. I hope I got to as many of the questions as I possibly could do in the hour that we have. We never have enough, but thank you for joining us.